So 25 years ago, if you came across a gastrointestinal stromal tumor, um, it was basically a death sentence, right?
Oh, absolutely.
Yeah.
I mean, it was completely disguised as just this smooth muscle mass.
Right. And you'd open up a patient, find this massive, highly vascular tumor invading the stomach or the bowel, and the standard surgical mindset just kicked in.
Which was just, cut it out, resect it.
Exactly. You clear the anatomical borders, but then within months or maybe a few years, it would inevitably come back.
Yeah, and completely immune to conventional chemotherapy.
Just invariably fatal. But today, well, that entire paradigm has been completely shredded.
It really has been.
And if you're a surgical trainee, especially one prepping for your FRCS exam, you can't just walk into that Viva knowing how to cut anymore.
No, not at all. You have to know how to read the genetic code.
Which is mind-blowing.
It is arguably the single greatest success story in the history of solid tumor oncology, honestly. We transitioned from relying purely on structural macroscopic surgery to treating a disease where the scalpel is now just, well, it's just one instrument in this highly orchestrated, molecularly targeted symphony.
A symphony, I like that.
If you approach a juice today as merely a mechanical obstruction to be excised, you are fundamentally misunderstanding the biology of the disease.
And that is exactly our mission today. We are taking a comprehensive, consultant-level journey through all of this.
The pathology, the pathophysiology, the risk stratification.
All of it. And the modern multidisciplinary management of GISTs. We've synthesized the absolute gold standard source material for you.
Yeah, we've got the latest ESMO, COMD, and an NCCN clinical practice guidelines.
Plus the incredibly specific College of American Pathologists, the CAP protocols, and these massive systematic reviews on the molecular genetics.
The overarching theme you'll see in all these sources is precision.
Right, precision oncology.
We are no longer guessing based on what a cell looks like under a microscope. We are identifying the exact typo in the DNA.
And then deploying a specific chemical weapon to neutralize it, right? While timing the surgery for the exact moment the tumor is weakest.
Exactly.
So let's start at the very beginning, the origin story. Because before 1998, pathologists were staring at these tumors and just completely misclassifying them.
They were. I mean, they called them leiomyomas or leiomyosarcomas because the cells they look like smooth muscle.
Right, or they'd see neural features and call them schwannomas.
But they weren't any of those things.
No, they weren't. And that confusion stemmed from the fact that GISTs arise from a really unique cell population in the gut, right?
The interstitial cells of Cano, the ICCs.
The ICCs.
Or sometimes from a shared stem cell precursor that was, on its way to becoming an ICC.
I've always found the interstitial cells of Cano to be one of the most elegant structures in GI physiology.
They really are fascinating. They're nestled deep within the layers of the muscularis propria.
The gut's internal pacemakers.
That's a great way to put it. Much like the SA node in the heart generates electrical impulses, the ICCs generate these spontaneous electrical slow waves.
Regulating peristalsis.
Exactly. They are the metronomes keeping the stomach and the intestines moving to a synchronized rhythm.
But when that metronome mutates, it doesn't just disrupt the rhythm, it initiates this cascade of uncontrolled cellular division.
And the mechanism of that mutation, that was the watershed moment back in 1998.
Right. A researcher named Hirota and his team found the smoking gun.
They did. They found that the vast majority of GSs, we're talking 85 to 90%, are driven by these activating mutations in specific tyrosine kinase receptors.
And they are mutually exclusive, right?
Yes, mutually exclusive.
Let's visualize a tyrosine kinase receptor for a second. I like to think of it like a highly sophisticated transmembrane doorbell.
A doorbell. Okay, I like where this is going.
Yeah, so normally a specific molecule ligand has to float up, bind to the outside of the receptor, and essentially ring the doorbell.
Right, and that physical binding causes two receptors to pair up or dimerize.
Exactly. Which then triggers a chemical reaction on the inside of the cell, usually telling the cell to grow and divide.
And once the signal is sent, the doorbell resets.
Right. So imagine a genetic mutation acts like a piece of tape stuck over that doorbell.
Ah, holding the button down permanently?
Yes. The cell is receiving this constant deafening signal to divide and multiply, completely independent of any external signals.
That is the perfect analogy for an activating mutation. And in GASTs, the most common doorbell being permanently pressed is the KIT receptor.
KIT accounts for the lion's share of these, doesn't it?
Oh, absolutely. KIT mutations are responsible for about 75 to 80% of all tests.
But if you're sitting in the FRCS Viva just saying KIT mutation is, well, that's nowhere near enough detail.
No, they will eat you alive for that. You have to know the specific chapters of the genetic code, the exons where these typos occur.
Because the location of the typo actually dictates the specific drug and dose you prescribe.
Exactly. Not all pieces of tape on the doorbell are the same.
Okay, let's break down these KIT mutations then.
The most common mutation, found in about 66% of cases, occurs in KIT exon 11.
Exon 11.
Right. Now, exon 11 codes for the juxtamembrane domain of the receptor. This is the structural hinge resting just inside the cell membrane.
So its normal job is to act as a physical brake.
Yes, keeping the kinase enzyme turned off when no ligand is bound. But when exon 11 mutates, that brake is just destroyed.
The kinase loop swings open and gets stuck in the on position.
Precisely. And clinically speaking, if a patient has to have a mutation, exon 11 is the one you want to see.
Without a doubt. Because they are exquisitely sensitive to standard doses of imatinib, right?
They are. Imatinib is our tyrosine kinase inhibitor, or TKI. It essentially acts as a microscopic wedge that sips right into the ATP binding pocket.
Blocking the energy transfer required to send the growth signal.
Exactly. For exon 11, the standard 400 milligram daily dosing works wonders.
But then we move down the receptor, and the story gets a bit more complicated. What about exon 9?
KIT exon 9. That makes up about 10 to 15% of cases.
And that's different from exon 11.
Very different. Exon 11 is inside the cell, but exon 9 codes for the extracellular domain.
So a mutation there mimics the effect of a ligand constantly binding to the outside of the cell.
Right, forcing the receptors to dimerize.
It's still pressing the doorbell just from the outside instead of breaking the hinge on the inside.
Yes, and this distinction is critical for the exam. Exon 9 mutated GSs are significantly less sensitive to imatinib.
Because the shape is different.
Exactly. The conformational shape of the receptor is just different enough that the imatinib wedge doesn't fit as perfectly.
So if the pathology report says exon 9, standard imatinib will likely fail.
You almost universally have to double the dose to 800 milligrams a day to force enough of the drug into the receptors.
Good to know. What about exons 13 and 17?
We do occasionally see mutations there, but they are rare as primary drivers, maybe 1 to 2%.
We usually see them later as secondary resistance mutations, right?
Yes, and we will definitely get to those later.
Yeah.
But we can't forget the second major player.
Right. What if the kitty doorbell is perfectly normal, but the tumor is still growing?
Then you are likely looking at the second most common driver, PDGFRA.
Platelet-derived growth factor receptor alpha.
Exactly. These account for roughly 5 to 10% of GSs. The receptors are structurally very similar to KIT cousins, essentially.
And just like KIT, you need to know the exons. Which one is most common for PDGFRA?
They most commonly hit exon 18.
And there is one specific typo in exon 18 that used to strike absolute terror into the hearts of oncologists.
You're talking about the notorious D842V mutation.
The D842V, that's an absolute must-know for the FRCS.
It is. This specific single amino acid substitution alters the activation loop of the kinase in such a profound way.
It locks it into an active conformation, right?
Yes, and it physically blocks standard TKIs like imatinib from binding. The pocket is just inaccessible.
So for almost 2 decades, finding a D842V mutation was a bleak prognosis.
Highly resistant to almost everything we had. But the clinical guidelines have a massive update here.
The landscape has changed.
Completely. The advent of a newer, highly specialized drug called ripretinib has revolutionized this specific niche.
Ripretinib.
Yes, it was engineered to specifically bind to the active conformation that D842V creates.
So as a modern surgeon, you aren't just reading GIST and prescribing imatinib blindly.
No, you are tailoring the molecule to the exact geometric shape of the mutated receptor.
Okay, so KIT and PDGFRA cover about 85 to 90% of cases. That leaves a stubborn 10 to 15%.
The ones that don't have typos in either of those genes.
Historically, they lumped all of these together under the term wild type.
Which is a huge misnomer. Cancer doesn't happen without a driver. They aren't truly wild, they're just driven by entirely different mechanisms.
Mechanisms we couldn't sequence back in 1998.
Exactly.
And the most important subgroup within this wild type category brings us crashing back to medical school biochemistry.
Oh, the Krebs cycle. It always comes back to haunt us in surgical oncology.
We're talking about SDH-deficient GSDISTs, succinate dehydrogenase.
Right. SDH is a crucial enzyme complex embedded in the inner mitochondrial membrane.
It has dual roles, doesn't it?
Yes, it participates in the Krebs cycle by converting succinate to fumarate, and it acts as complex 2 in the electron transport chain.
So what happens when there is a mutation or epigenetic silencing of the genes that code for its subunits, like SDHB or SDHA?
The entire assembly line just breaks down. The enzyme fails, and you get a massive intracellular accumulation of succinate.
And succinate isn't just a harmless byproduct.
Not at all. At high concentrations, it leaves the mitochondria and acts as an oncometabolite in the cytoplasm,
Competitively inhibiting a whole family of enzymes called alpha-ketoglutarate-dependent dioxygenases.
which is catastrophic for the cell's regulatory mechanism,
Profound DNA hypermethylation, right?
essentially silencing tumor suppressor genes. Plus, it stabilizes a protein called HIF-1 alpha.
Even when there's normal oxygen around.
Right, which tricks the cell into a state of pseudohypoxia. The cell thinks it's suffocating.
So it frantically upregulates growth factors like VEGF and PDGF to create new blood vessels.
It's a completely different pathway to tumor formation than the simple broken doorbell of a KIT mutation.
The mitochondria essentially become a chaotic cancer factory, and these SDH-deficient gistes have massive implications for the patient's family, don't they?
They absolutely do. If you resect a gist, and the pathology comes back as SDH deficient.
Which is determined by a lack of SDHB staining on IHC, right?
Exactly. If you see that, your clinical radar has to shift immediately from a localized surgical problem to a potential systemic syndromic condition.
Especially if the patient is young.
Yes, children or young adults. That brings us to the classic FRCS syndromic associations.
Let's map these out clearly for everyone listening. First, the Carney triad.
The Carney triad is fascinating. It's a non-heritable condition, predominantly affecting young females.
And it consists of 3 specific tumors, right?
Multifocal gastric gistes, pulmonary chondromas, and extraadrenal paragangliomas.
Such a random assortment of tumors. The stomach, lung cartilage, and sympathetic nervous system.
But they are all tied together by this underlying SDH dysfunction.
And we have to differentiate the Carney triad from Carney-Stratakis syndrome.
Right. While the Carney triad is non-heritable and involves pulmonary chondromas, Carney-Stratakis syndrome is an inherited autosomal dominant condition,
Driven by actual germline mutations in the SDH genes.
meaning the patient inherited the broken gene. This syndrome presents as a dyad, gistes and paragangliomas.
So if you diagnose Carney-Stratakis, you are obligated to refer the family for genetic counseling.
Absolutely obligatory.
And since we're listing syndromic gistes, we cannot skip neurofibromatosis type 1.
NF1 is another critical association. These patients have a significantly higher risk of developing gistes.
And they're usually in the small bowel, right?
Yes, often multiple, and crucially, they are true wild type for KIT and PDGFRA.
Meaning, if you blindly throw imatinib at an NF1-associated gist, you are going to be very disappointed.
They simply don't respond to standard TKIs because the KIT pathway isn't the primary driver.
Okay, so we've covered the cellular origins and the molecular engines. Let's look at how we actually prove what we're dealing with under the microscope.
The College of American Pathologists, the KIT protocols, are very exhaustive on this.
The pathologist begins with the morphology, right?
The architectural layout of the cells. About 70% of gistes present as the spindle cell type.
Long, sweeping fascicles of elongated cells.
Tight-packed, exactly. Another 20% are epithelioid rounder, polygonal cells that can look strikingly similar to a carcinoma.
And then the remaining 10% are mixed, but staring at the shapes isn't enough anymore.
No, a spindle cell GIST looks almost identical to a leiomyosarcoma on a standard H&E stain.
Which is why immunohistochemistry IHC is the absolute bedrock of a GIST diagnosis.
Mandatory. The first and most vital stain they apply is CD117.
That's the protein product of the KIT gene, right?
Yeah. Yes. If the KIT gene is overactive, the cell surface will be plastered with CD117. Roughly 95% of all gistes will stain strongly positive for it.
They also stain for CD34 positive in about 70 to 90%.
Right.
Hold on, let me stop you there. If 95% of GCs are CD117 positive, that explicitly means 5% are CD117 negative.
Yes, it does.
If I'm staring at a pathology report and the CD117 stain is negative, my immediate reaction is that it's not a GIS.
And that is phenomenal catch. It highlights one of the most dangerous diagnostic traps in GI pathology.
How can we diagnose that remaining 5% confidently? We can't just guess.
This is exactly why a newer IHC marker called DOG1 was introduced.
DOG1, discovered on GIS1.
Literally named for where it was found. DOG1 is a highly specific chloride channel heavily expressed in the ICCs.
And what's the magic number for DOG1?
It is positive in 98% of Gs.
Right.
Crucially, it is frequently positive in those rare cases that are CD117 negative.
So DOG1 acts as our safety net.
Exactly. If you have a suspected tumor that comes back CD117 negative, you reflexively check DOG1.
But what if both CD117 and DOG1 are negative, but the morphology still strongly suggests a GIST?
The guidelines mandate that you must proceed to molecular genotyping, extract the DNA, and sequence it.
Because those double negative tumors are highly likely to harbor a PDGFRA mutation.
Precisely. Differentiating this from a desmoid fibromatosis is vital. Giving imatinib to a desmoid tumor is useless.
And giving it to a PDGFRA D840Phi mutated GIST is equally futile. The precision required is astonishing.
It really emphasizes why you need a specialized sarcoma pathologist.
Let's shift our focus to the macroscopic patient sitting in the clinic. Who gets these tumors and how do they present?
Demographically, the median age is around 60. No strong sex predilection.
And where are they most commonly found?
The stomach is unequivocally the most common site, about 51 to 60%. The small intestine is next, 30 to 36%.
The colon and rectum are pretty rare then.
Very, maybe 5 to 7%. Esophageal is about 1%.
So if these mutant pacemakers are buried deep inside the muscle layer of the gut, leaving the surface mucosa intact, how do we even know they are there?
A massive proportion are discovered completely incidentally.
Really, just walking around with a ticking time bomb?
Yeah, a patient gets an upper endoscopy for acid reflux, and the gastroenterologist notes a smooth, bulging submucosal mass.
Covered by normal pink mucosa.
Or they get a CT scan for a kidney stone, and the radiologist spots an asymptomatic mass on the stomach.
But when they do cause symptoms, what are the red flags?
The symptoms are directly tied to the tumor's physical growth mechanics. They can grow exophytically, pushing outward toward the abdominal cavity.
Or endophytically, pushing inward into the gut lumen. Or both, creating a dumbbell shape.
Exactly. Now, as the tumor grows larger, it requires a massive blood supply.
And eventually outgrows it, right?
Yes, the core becomes necrotic. When an endophytic tumor undergoes central necrosis, it physically erodes through the overlying mucosa,
creating a deep ulceration. And an ulcerator highly vascular tumor in the stomach means bleeding.
Profound bleeding. GI hemorrhage is the most common symptomatic presentation,
ranging from occult bleeds causing anemia to acute hemorrhagic shock.
Other symptoms are mass effect vague abdominal pain, early satiety if it's compressing the stomach,
or serving as a lead point for an intussusception in the small bowel.
Presenting as an acute bowel obstruction, yes.
Okay, picture this. You're the senior registrar on call. A 62-year-old patient rolls in with melena and a drop in hemoglobin. You suspect an upper GI mass. What's the definitive imaging?
The absolute gold standard for staging is a high-quality, contrast-enhanced CT scan of the abdomen and pelvis.
But not just a generic scan.
No, you must specifically request arterial and portal venous phases.
Why the specific multiphasic timing?
And because GISTs are hypervascular, on the arterial phase, they enhance brightly, allowing you to clearly define the feeding vessels.
And the portal venous phase?
You are meticulously scanning the liver. GISTs metastasize almost exclusively via the hematogenous route to the liver or direct seeding to the peritoneum.
Is there a role for MRI?
CT is sufficient for most, but MRI is heavily preferred for characterizing indeterminate liver lesions.
Like trying to tell a cyst from a metastasis.
Exactly. The other scenario is rectal GISTs. The pelvis is a rigid, narrow funnel. You need the exquisite soft tissue resolution of an MRI to map out the tumor's relationship to the sphincter complex.
What about PET scans?
PT-CT is absolutely not for routine staging.
Really? In many other oncology pathways, it's standard.
Not here. It's only for early response evaluation.
Oh, meaning to see if the imatinib is working.
Exactly. Before the tumor physically shrinks on a CT, a sensitive GIST will completely shut down its metabolism on a PET scan.
It goes from glowing hot to completely dark in days or weeks. That's incredible.
It provides near-instant reassurance.
Okay, so we have imaging. Now we need a tissue diagnosis. And this is where we hit a massive controversial pivot.
The biopsy conundrum.
Right. If I see a colon mass, I grab a biopsy forceps. A pancreas mass, percutaneous core, biopsy. But with GISTs, the guidelines throw up a massive stop sign. Why?
This is a classic trap for the uninitiated surgeon. The biology of a GIST makes traditional biopsy incredibly risky.
Because they're usually encased in a fragile cedar capsule.
Soft, friable, and packed with blood vessels under pressure.
So if it's a localized, resectable intra-abdominal mass, you strictly avoid percutaneous biopsy.
Yes. Puncturing that capsule risks catastrophic hemorrhage. And worse, you risk cracking microscopic tumor cells along the biopsy path.
Spilling them into the pristine peritoneal cavity, condemning the patient to peritoneal carcinomatosis.
Exactly. The rule is, if it's resectable, don't poke it.
But wait, we just spent 20 minutes saying we must know the exact genetic mutation. We can't know the genotype without tissue.
Right.
So if we have a massive tumor we can't operate on immediately, and we need to start neoadjuvant imatinib, how do we safely get the tissue? We're in a catch-22.
It is a delicate balance, but endoscopic ultrasound, or EUS, is our elegant solution.
Bypassing the abdominal cavity entirely.
The gastroenterologist advances the probe down the esophagus and visualizes the mass from inside the gut lumen.
And passes a needle directly through the stomach wall into the mass.
EUS-guided fine needle biopsy. Any spillage happens directly into the highly acidic lumen of the stomach, where cells are destroyed.
Zero risk of seeding the peritoneum. And you don't just use standard endoscopic biopsy forceps because the overlying mucosa is normal.
Precisely. Forceps just bite off normal mucosa. You'd miss the tumor completely.
All right, we've safely diagnosed it. Now we figure out how dangerous it is. Risk stratification.
Which completely clashes with old-school binary surgical thinking.
Right, the old benign versus malignant boxes.
That terminology is entirely discarded for GISTs. There is no such thing as a truly benign GIST.
They exist on a spectrum. Even a 2-centimeter nodule has a non-zero potential to metastasize.
We classify them by their clinical risk of malignant behavior. Very low, low, intermediate, and high risk.
How do we calculate this risk? What are the variables?
4 primary prognostic variables. First is tumor size.
Mm-hmm.
The larger the tumor, the more time it's had to mutate.
And the second variable, this one gets technical.
The mitotic rate. A direct microscopic measurement of cell division. And here is a crucial high-yield update for the FRCS exam.
The shift from high-power fields.
Older textbooks always said mitosis per 50 high-power fields, or HPF. But the new CIP protocol mandates expressing it as mitosis per 5 square millimeters.
Why abandon the high-power field?
Because it's not standardized. It entirely depends on the microscope's physical hardware. Older microscopes had narrower lenses.
So someone using a modern wide-angle microscope is physically looking at more area?
Yes, meaning they are mathematically guaranteed to count more dividing cells. This caused artificial stage migration.
Patients were labeled high risk just because their hospital bought a newer microscope.
Exactly. Standardizing it to exactly 5 square millimeters eliminates that hardware variability.
That is fantastic detail for the exam. Okay, size and mitosis. Third variable.
Location. A 6-centimeter GS in the stomach has a low risk of recurring. That exact same tumor in the jejunum or rectum has a drastically higher risk.
Gastric GSs inherently have a better prognosis. And the fourth variable.
The surgical nightmare. Tumor rupture.
Spontaneous or intraoperative? I always think of tumor rupture as opening Pandora's box.
It's an unmitigated disaster. Spilling those mutated cells instantly escalates the patient to the absolute highest risk category.
Demanding prolonged systemic therapy. So how do we synthesize these 4 variables into a scoring system?
You need to know 2 systems. The older AFib criteria incorporates size, mitosis, and anatomic site.
But the one favored by modern guidelines is the Junsu criteria, right?
Yes, the modified NIH criteria. Junsu was the first to formally integrate tumor rupture as an independent high-risk factor.
If it ruptures, it doesn't matter if it was tiny. It's high risk.
Modern oncology is also moving toward risk contour maps or heat maps.
Plotting the exact size against the exact mitotic count to give a personalized percentage of recurrence over 10 years.
It transforms a vague label into actionable data for shared decision-making.
Okay, the multidisciplinary team has weighed in. Time for surgery. Part 4, surgical management. What are our non-negotiable principles?
The paramount goal is an R0 resection, removing it in one intact piece with visually and microscopically negative margins.
But we don't need massive 5-centimeter margins like in adenocarcinomas, do we?
No, GSs push tissues away rather than infiltrating deeply. A 1 to 2 centimeter gross margin is entirely sufficient.
What if we get a microscopic R1 margin back from pathology? Do we immediately reoperate?
This is highly nuanced. Uniquely for GSs, a microscopic R1 might not strictly mandate immediate re-resection if it causes major morbidity.
Like converting a simple wedge into a total gastrectomy.
Right, with effective adjuvant imatinib, Retrospective data suggests an R1 margin doesn't significantly worsen overall survival compared to R0 in these complex cases.
Though R0 is always the goal. Now, why aren't we performing prophylactic D2 lymph node dissections like we do for gastric adenocarcinoma?
Because GSs are sarcomas. They're mesenchymal, not epithelial. They do not respect the lymphatic system.
Spreading hematogenously instead.
Lymph node metastasis is exceptionally rare, maybe 1 to 2%. A D2 dissection just adds operative time and morbidity with zero survival benefit.
Only resect nodes if they are grossly suspicious. So the surgical procedures are actually quite conservative, wedge resections to preserve function.
Laparoscopic resections are standard of care for favorably located tumors, but there is a massive caveat.
A no-touch technique.
You must handle the tumor with extreme paranoia. Never grasp it directly with forceps.
Because if you squeeze it, the pseudocapsule pops. Pandora's box opens.
Always manipulate the normal healthy tissue surrounding it.
Terrifyingly fragile. Let's bring the medical oncologist back in. Part 5, neoadjuvant and adjuvant therapy. When do we delay surgery and give imatinib up front?
Neoadjuvant imatinib, usually 400 milligrams daily, is for 3 primary indications. First, if a tumor is borderline resectable or massive, we cytoreduce it until R0 is possible.
Second is function sparing.
Like a rectal GIC just above the sphincter. Shrinking it with imatinib for 6 to 12 months might allow a local excision instead of permanent colostomy.
And the third indication ties back to Pandora's box, decreasing the risk of intraoperative rupture.
Neoadjuvant imatinib induces tumor necrosis and creates a denser fibrotic capsule. It hardens the tumor, making it vastly safer to handle.
Now, why only 6 to 12 months? Why not 24 months until it vanishes completely?
It's a biological cat and mouse game. They almost never vanish completely. Maximal shrinkage peaks between 9 and 12 months.
If you leave it too long, you risk clonal evolution. The tumor adapts.
A subpopulation acquires a secondary resistance mutation, and suddenly it starts growing again. You miss your surgical window.
So you operate when maximal response is achieved. And adjuvant therapy. Who gets imatinib after successful R0 surgery?
High-risk patients based on Donazu criteria. We have to assume microscopic metastatic cells are circulating.
And the duration is definitively settled, right?
Yes. The SSGX-8 trial randomized patients to 1 year versus 3 years of adjuvant imatinib.
The 3-year arm showed massive improvements in recurrence-free and overall survival.
So 36 months is the absolute gold standard for high-risk resected GISTs.
But we don't hand it out blindly. Genotyping is mandatory.
Clinical malpractice not to. KIT exon 11 gets standard 400 milligrams, exon 9 gets 800 milligrams.
And PDGFRA D842V.
Standard imatinib is worse than useless. You must advocate for avapritinib.
It's incredible. The pathology report literally writes the prescription. But biology is relentless. Let's look at the endgame: metastatic disease and overcoming resistance.
When it's systemic, our goal shifts from cure to long-term disease control, using a sequential ladder of TKIs.
First line is imatinib 400 milligrams. If they progress, check compliance, then maybe escalate to 800 milligrams.
Doubling the dose often recaptures control if it's just gene amplification.
But eventually, the tumor brute forces a new key: secondary point mutations in KIT exons 13, 14, or 17.
Imatinib literally cannot fit the receptor anymore, so we move to second line, sunitinib.
What's sunitinib doing differently?
It's a multi-targeted TKI. It binds even with exon 13 and 14 mutations, and it blocks VEGF receptors, starving the hydrovascular tumor of its blood supply.
But the hydra grows another head.
An exon 17 activation loop mutation swings out and blocks sunitinib. So we climb to third line, regorafenib.
Which maintains activity against exon 17. And the newest guidelines have a fourth rung:
Ripretinib, a massive biological breakthrough. It's a switch control kinase inhibitor.
bridge control.
Instead of just shoving a wedge into the pocket, it binds to the actual physical switch mechanism, the hinge. It locks the kinase off entirely, regardless of the multiple chaotic mutations.
As a surgeon, I have to ask, if a patient is on fourth-line therapy with liver metastases, is there ever a role for the scalpel again?
Yes, but with exquisite, highly selective multidisciplinary patient selection. 2 specific scenarios.
First scenario:
debulking during disease response. If a patient's 10 liver metastases shrink and stabilize on imatinib, we know microscopic resistant clones are brewing.
weeding the garden, removing the macroscopic breeding ground.
Exactly. Potentially adding years to the imatinib's efficacy.
And the second scenario:
Unifocal progression. 9 lesions remain perfectly suppressed on imatinib, but 1 specific lesion starts rapidly growing.
it figured out the lock.
If we switch the whole systemic therapy to a toxic drug just for that 1 rebel lesion, we expose the patient to massive side effects. Instead, the surgeon cuts out that one rogue nodule,
leaving the patient on the highly effective imatinib for the rest. A true cat-and-mouse game.
extending life expectancies from 12 months in the pre-imatinib era to over a decade today.
Let's pull this all together for the trainee. We went from guessing cell shapes to sequencing exact KIT mutations.
Learning why we must achieve R0 abandoned lymph node dissections and use the no-touch technique.
A modern FRCS surgeon must think like a molecular biologist to time their surgical strikes.
And as we look to the future, consider liquid biopsies.
Detecting circulating tumor DNA from a simple blood draw.
It's an imminent reality. We might soon monitor the exact moment a GCD develops a secondary resistance mutation in the blood, swapping their TKI weeks before a CT scan ever shows it growing.
Real-time molecular monitoring fundamentally changing the surgical follow-up clinic, something every trainee needs to be ready for.